arthroplasty. Now, if you're stuck with a failure of a tibial component after kinematically aligned total knee arthroplasty, you can perform a revision, and this little section talks about revising just the tibial implant is usually all you have to do to manage tibial component failure after calipered kinematically aligned total knee arthroplasty. The first step is to check your verification worksheet or go back to the op note and see whether your distal femoral resections that you measured and that you recorded on the verification sheet here, and the posterior resections that you measured and compared their thickness and adjusted for cartilage wear and the kerf of the blade match that of the posterior thickness of the condyle here. And when you know that the femoral component has been kinematically aligned, then there's no reason to revise the femoral component. So option 1, when failure occurs early, most commonly you did not restore the native slope. It can be reverse, but more commonly it's excessive. And then you need to revise the tibial component and do so by restoring the native posterior slope. So here's an example where we see that the patient's limb alignment is excellent. This is a very large patient, about 350 pounds, but he's 6'11", so his BMI is quite reasonable for his body size. But you can see this posterior overload in the tibia with the bone remodeling and the anterior translation of the tibia on the femur. The slope was set at 10 degrees, and the contralateral knee of the same patient is only 4. So we violated our cardinal principle of not placing the slope in more than 4 degrees from the native and increased it 6 degrees by mistake, and this promoted our failure of the tibial component. When we go back and we look at the bone resections in this particular patient, the thicknesses did match those of the thicknesses of the condyles of the femoral component after correcting for the kerf and the thickness of the blade and cartilage wear, and so we then only had to go and revise the tibial component. We did so by restoring the native slope. We were able to retain the PCL, and we just used a little longer stem. And so now we reduced the slope where it was 4 on the contralateral side, it's now 2 within 2 degrees, and that should give us a satisfactory outcome. So here's a patient that had native coronal alignment restored, posterior slope greater than native, and this was the patient I showed earlier where I made a surgical error. There was just no excuse for placing this slope at 12 degrees, and this contralateral knee was 2. And so we, once again, this patient had patellofemoral arthroplasty or arthritis. All the cuts were appropriate after we compensated for the wear and the kerf of the blade, and so we achieved kinematic alignment of the femoral component. So we just revised it with a cone and a long stem, and once again restored the native limb, joint lines, and slope. So there's the slope at 3, and our target was 2, so we hit it quite nicely. Option 2, when failure occurs late, typically 8, 9, 10 years, then exchange the worn insert with another that is a little bit thicker to reduce the AP movement and to tighten the flexion space, and if possible, add more constraint to the insert if it's available. So this is a 65-year-old skier 10 years after a left kinematically aligned TKA. He presented with effusions and mild instability, and you can see the symptomatic knee is the left one. There's a little bit of narrowing on the lateral side, and you can see that the slope on the symptomatic knee. So caliper measurements verified the femoral component was kinematically aligned at the time of the index surgery. So we went back and just put a thicker insert in, and this we think was caused by the use of an ACL and partial meniscal deficiency CR insert, and the use of an MS or medial stabilized implant might have reduced the risk of posterior overload in this particular patient. So to summarize, early failure of a kinematically aligned total knee arthroplasty treated with a CR implant is rare. The onset averages about 28 months, and the cause is not matching the native slope, most typically putting in greater posterior slope than the native slope of 4 degrees or more. Verification checks that restore the native slope and flexion laxities can reduce the risk of early tibial component failure, but depending on the constraint of your implant, there may be a risk for late failure from posterior overload due to excessive anterior translation of the tibia or excessive posterior rollback of the femur. The use of an MS implant that provides AP stability is a strategy for reducing the risk of late failure from posterior insert wear. And finally, revision of just the tibial base plate and the CR insert manages most tibial component failures when the femoral component is kinematically aligned and the PCL provides stability.